If you can, yes. uh,
Yes, we can hear you clearly.
and thank you for joining on Saturday. And we welcome you all on behalf of British Pakistani Cancer Association, which is fairly a young forum, which may not be cannot be successful without your active participation. The members of this forum at the moment, they are the pioneers just to take the responsibility to provide you a forum where you can have educational activities and non-educational activities as a valuable Pakistani oncologist, hematologist. So today what we are going to do is we are going to do ESMO updates on breast cancer. Rule of business are very simple. They are not stringent like the way we normally see in face-to-face meetings. Um, we will do the presentation first. After that, there'll be a question answer session. And at the end, I mean, you will be more than welcome to ask questions, but I would appreciate if you raise your hand. If someone wants to send a question in a written form, then please do text it individually to me. Um, or even you can put it on general chat as well. So Dr. Iqtedar Muazzam, one of our valuable consultant medical oncologist colleague, working in Hull and visiting consultant in Northern Lincolnshire and Goon Hospital. He has attended ESMO this year, and I would like him to summarize all the salient updates on breast cancer. So over to Iqtedar. Thank you.
Thank you so much, Vakas, for your kind introduction. As you have mentioned, I'm a medical oncologist and working in different organizations, as shown on the first slide. But I think my journey with internal medicine and oncology, my career started at Shaukat Khanum Cancer Hospital. So I'll take a couple of minutes just to introduce myself. So kindly bear with me. Can you hear me? Right. Vakas, can you hear me?
Yes, we can hear, Dr.
We can hear you. And can I request everybody to keep their mic muted, please? Thank you.
So my career started at Shaukat Khanum Memorial Cancer Hospital. I worked there for 8 years, 4 years in internal medicine and 4 years in medical oncology. And I am proud to be the first resident of Shaukat Khanum Cancer Hospital who completed his training in internal medicine and did his FCPS. So I was the first FCPS in medicine, worked with one of the best internists in Pakistan, Dr. Mansoor Javed, Dr. Faisal Sultan, Asim Yusuf, Dr. Hussain. So you could see their pictures below. And also when I started oncology, I was very lucky that I worked with Dr. Narjis Muzaffar, Dr. Athar Kazmi, great contribution in my career in oncology. And I was the first fellow to do FCPS in medical oncology at Shaukat Khanum Cancer Hospital. But the biggest turn in my career was when I started to work with Dr. Neelam Siddiqui. You can see that she visited us in Hull thanks to Dr. Bhatt to attend our breast cancer annual symposium. And it was my honor that I was chairing her session, did a great talk, learned all the principles of medical oncology from her, which I still I use in my current practice. And then second part of my career was at UK. I am in Hull University teaching hospitals for more than 10 years now. And I'm in UK and I'm in Hull because of Dr. Bhatt. A huge amount of contribution, and I'm so thankful to him, and he's still very kind to me. Dr. Bhatt, again, I am proud to be his first Pakistani medical oncology specialty doctor to complete CSER in medical oncology and get into the specialist register. It's not that I'm the only one. You can see a picture below that there are a number of oncologists, medical and clinical, who were initially under training by Dr. Neelam Siddiqui and Other valuable colleagues, Dr. Shahid Hamid, and now they are all working in Hull. Some of them have left, some of them are not in the picture. So it's a sort of big group. So now coming back to the main agenda, which is ESMO Congress of this year. This was in Barcelona, a place called Fira Barcelona. It's a big center with there are multiple halls. Very good place to attend that meeting. All the facilities were there. It was a very enjoyable meeting. The place was very much accessible through train and through tram. All sessions were very well organized. And Barcelona itself, it's a beautiful city. I mean, full of culture, full of heritage, very well accessed. It's the home ground for Barcelona FC, and Dr. Butt can tell us how important this Barcelona club is. There are old buildings. There is a new town center. The coast, it's beautiful. So if you are in Barcelona, you want to go back to Barcelona. So now coming to the main agenda, the best presentation, which they call the presidential presentation in ESMO, one of the most important practice-changing trial, which showed that early stage immunotherapy significantly prolongs overall survival in triple-negative breast cancer. Was it a new news? No, it was not new to us, because Merck had already announced in that keynote 522 trial has met its secondary endpoint of overall survival. Patients with high risk early stage triple negative breast cancer, they were, with the use of immunotherapy and chemotherapy, they were now achieving overall survival benefit as well. But this was our opportunity to see how well it has done, what was the magnitude of benefit. So this was a phase 3 trial, as expected. The eligibility criteria was that adult patients newly diagnosed triple negative cancer, and triple negative means that they were ER, PR, and HER2 negative. Patients had to have T2, which is 2 centimeters or bigger size of disease, to be enrolled in the study, or the size could be less than T2, as long as these patients were node positive. So obviously these patients were high risk patients. The schema of trial was that patients had to have 4 cycles of carboplatin and paclitaxel, followed by 4 cycles of anthracycline and cyclophosphamide, and it was given with or without pembrolizumab. This is a slightly different chemotherapy regime which we use in United Kingdom. We use generally 3 cycles of chemotherapy, but ever since carboplatin has come to our practice, we have gone to 4 plus 4 cycles. After that, patient had surgery and they had to complete remaining part of pembrolizumab to complete 1 year. Half of the patients were on pembrolizumab and half of the patients were on placebo. This is what we already know about this study. So pembrolizumab for triple negative breast cancer, the initial publications and presentation of the trial showed that it improves pathologic complete response. And we have idea from our chemotherapy trials that pathologic complete response means better overall survival. It's a great surrogate endpoint. However, whether it is true for chemoimmunotherapy, it was not known, and this trial was going to tell us about it. We know that patients who have better pathologic complete response have better event-free survival, and event is recurrence of breast cancer or death. We know that with use of addition of pembrolizumab to chemotherapy, the pathologic complete response goes up from 51% to 64%, which is difference of about 13.6 percent points. Event-free survival improves from 85% to 91%, and that actually again improves the odds by hazard ratio of any event or death by 0.63. In terms of high-grade toxicities, they were more or less the same in both arms. So the overall survival outcome in ESMO, it showed that the overall survival at the point of 48 months, at actually 60 months, 5 years, it had gone up from 81% in the chemotherapy arm only to 86% if immunotherapy was added. And this is a great endpoint, because we are using immunotherapy in many cancers in adjuvant setting, very few cancers in neoadjuvant setting. We are making our decisions based upon disease-free survival data, or we are also making our decisions based upon event-free survival data, but very few trials actually. I think this trial and another trial in kidney cancer, these are the only trials which have proven overall survival benefit with use of immunotherapy. So that actually helps in building our confidence. That actually tells that this treatment not only prevents cancer from coming back, but it also increases chances of cure. We can say it with confidence now. So just to summarize, addition of pembrolizumab to neoadjuvant chemotherapy improves absolute pathologic complete response gain by 13.6%. The hazard ratio is 0.63. Whether it improves overall survival, yes, it does. 5% of patients, more patients are cured by addition of pembrolizumab to chemotherapy. But remember, looking at the graph, still 15% of triple negative breast cancer patients will die despite using pembrolizumab. And the other important point and very, very interesting point is that 80% of breast cancer patients will be cured even if immunotherapy is not used. So it means that there is modest improvement in overall survival, but 5% is a big number if we are treating breast cancer medical oncologist. So where it takes us, there are still some controversies, like we talked about 20 millimeter or higher breast cancer size, which will be eligible for this trial. What about a premenopausal patient, triple negative cancer, and patient had tumor size 19 millimeter? So technically, these patients won't be eligible for the trial, and most of the regulatory approvals will not allow using it. But whether this 1 millimeter difference will make this so much change, or we have a 35 years old patient, grade 2 IDC, ER0, PR4, HER2 negative. So this was one of my patients. So say it's not 19, say that the size of the tumor is 20 millimeters, but patient is not fully triple negative. Whether this patient will be eligible for these medicines, obviously not eligible for the trial. So these are the points which are not clear from this study. And what about a triple negative patient who does not have typical invasive ductal carcinoma, or one of the typical pathologies which we see? Say this patient has adenoid cystic carcinoma, which are not very chemosensitive, or metaplastic carcinoma, which are not chemosensitive. Whether these patients would be eligible for immunotherapy. So we have to make these decisions based upon case reports, individual experiences, based upon our regulatory approvals, and the answers are not clear. But thankfully, these patients are minority. Majority of our patients would be eligible for this drug. So what about an easy case, 35 years old, premenopausal, triple negative breast cancer, presented with 21 millimeter right breast cancer mass, no axillary lymph nodes. So this patient received treatment according to 522. 10 months later, patient had complete pathologic response, but this fit, healthy young lady who is going to see decades of life in future will be using levothyroxine or hydrocortisone replacement, because this patient developed immunotherapy related thyroiditis or immunotherapy related adrenal insufficiency. So these are some difficult facts. The bottom line is immunotherapy is here. Immunotherapy is now in breast cancer. So if immunotherapy is available and your patient is eligible, and patient is in agreement, patient will get immunotherapy. But we have to discuss the points which were made initially, that 80% of the patients will be cured just with chemotherapy treatment, and there are small risks of immune related toxicities. Some of them can be permanent, some of them can be lifelong. We have to speak with our patients openly and talk them through clearly. In terms of using immunotherapy, we are using immunotherapy in multiple settings, more so in advanced cancer settings rather than early cancer settings. And what I have noted is that my clinic conversations are going more and more complicated and longer in immunotherapy patients who are receiving it in adjuvant, neoadjuvant setting. In metastatic setting, in most cases, we are already dealing with life-limiting disease. Here we are treating patients who will be cured otherwise, but with use of immunotherapy, they can have lifelong limitations. And I do kidney cancer as well, just like Dr. Ali does. And in our experience, there are patients who, despite having intermediate high risk of cancer recurrence, they decline using immunotherapy. I haven't seen it in breast cancer patients, because somehow breast cancer patients want everything what they want. And some of my patients in practice have suffered serious complications with immunotherapy. So we have to be very, very open and very, very honest with our patients. In my practice, after having that informed discussion, this is patient's decision whether they want to have immunotherapy. And if we are in a place where immunotherapy is difficult to get, remember 80% of breast cancer, triple negative cancer patients will be cured at early stage, even without use of immunotherapy. So I will go to the next part of discussion. This is again a common scenario from our practice. Like another 35 years old female, premenopausal, presented with right breast lump, positive axilla, grade 3 invasive cancer, ER positive, PR positive, HER2 positive, had curative breast cancer surgery, lymph node positive disease, staging CT scan negative, had adjuvant systemic treatment with chemotherapy, standard of care, and use Herceptin. So we do not normally use Herceptin for all our node positive patients. We have a different practice, but for the sake of this discussion, say this patient had Herceptin treatment. The question is, what about endocrine therapy? What about ovarian function suppression? Because we know from soft and text trial that ovarian function suppression improves overall survival and disease-free survival in hormone receptor positive, HER2 negative breast cancer. What about HER2 positive patients? Because there were none or minimal patients who were HER2 positive in that trial. And we know that in HER2 positive breast cancer patients, at least first 2 to 3 years are driven by chemotherapy and most likely from anti-HER2 treatment. So whether these patients would benefit from addition of endocrine treatment and especially ovarian function suppression if these patients are patients at a stage whereby they are premenopausal and would benefit from ovarian function suppression. So there was a study presented. It was non-randomized. I'm sorry, the slides I can't show you properly because I'm not on my regular laptop. But anyways, the use of ovarian function suppression, this was a retrospective analysis of HERA trial. And HERA trial, we know, is the one which was the regulatory, one of the first regulatory trials to approve Herceptin, establish Herceptin as the standard of care in adjuvant setting of HER2 positive breast cancer patients. So this was a retrospective analysis of HERA trial, ER positive, HER2 negative cancer, HER2 positive cancer patients. And what they found was that the use of ovarian function suppression in eligible patients resulted in higher overall survival and disease-free survival. But remember, this was not a randomized trial, and now we are not using HERA trial protocol in all patients, but this is something which we can use as a talking point with our patients. Even more common scenario, which I see in my practice, and I'm sure those who do breast cancer see 1 or 2 similar patients every day in their practice. A 34 years old, premenopausal, ER positive, PR positive, HER2 negative. She had curative surgery, chemotherapy, radiation, started on ovarian function suppression, letrozole, and this is what happens after that. Significant joint stiffness, hot flushes, sweats, sleepless nights, mood changes, weight gain, fatigue, loss of interest in their life, low mood, and even suicidal thoughts. Many women who are like 30, 35 years of age, they will say that we are feeling like an 80 years old lady. So what is the common request of these ladies? Can we stop our endocrine treatment? Can we take a break? Can we do something else? So like this patient wanted to stop initially endocrine treatment for 180 days, then asked for 90 days, and then finally asked, could she have at least 30 days off so that she could have some life. On the other hand, once these women stop these medicines, they start to get worried about their effect on their survival. And this is such a difficult question to answer. So these women are between devil and the deep. They can't stop their treatment. They can't take the treatment. Endocrine treatment is not easy treatment. We say that chemo is difficult. Endocrine treatment, I feel sometimes in some patients, it's even more challenging to give. So this was, again, a retrospective analysis from French healthcare system. They looked at non-adherence of endocrine treatment in different age groups and for different duration. And they determined what was the effect on survival. So I would like your attention to right side of this figure, whereby 5-year survival in percentage is given. And you can see that those women who, younger the women, better was the survival benefit if there was no break. And even 30-day break, not having 30-day break had significant improvement in survival time. Yes, this was a population-based study, so there will be a lot of bias in that, but there will be a lot of truths. And obviously, if you will tell your patient, they will not like you, but that's the reality. that these patients need to carry on with their hormone treatment without a break. We all actually eventually agreed to break because these treatments do affect their quality of life. And we know that quantity and quality, we have to take balance in between. On the other hand, if this patient with similar scenario is 44 years old, let's see what happened. These patients possibly can have little bit of break with minimal impact on their expected survival benefit. However, take this trial as a pinch of salt, and I would say take all the measures which you can in your clinical practice to avoid any break, because non-adherence, it increases with at younger age, and it has impact on the overall benefit. Another interesting trial was adjuvant ribocyclic study, NETLI trial. We use abemaciclib in adjuvant setting in UK, Europe, and rest of the country, rest of the world. The difference between NETLI in adjuvant ribociclib and adjuvant abemaciclib trial was presence of node-negative cancer patients. So adjuvant abemaciclib is approved for node-positive patients, generally women who have heavy axilla, and which means that they are at very high risk of breast cancer recurrence, or in lighter axilla, 1 to 3 positive nodes, if they have larger size, more than 5 centimeters, or higher grade. In a NETLI trial, even node-negative patients were enrolled, although node-negative patients were not eligible in the abemaciclib trials. So the schema was patients were randomized to receive ribociclib with or without use of non-steroidal AI. And the duration of treatment was 3 years, in contrast to 2 years, which we use for abemaciclib. On this ESMO, they presented 4-year landmark analysis, which was IDFC, so invasive disease-free survival in ITT population. We already had data from 36 months, whereby use of ribociclib had improved disease-free IDFC or endpoint from 88% to 90%, so 2.7% delta. Here, they presented 48 months data, which was even better. So the curves have started to separate. And now this is important because this is the first data whereby patients have stopped taking ribociclib. And just like we have seen in abemaciclib adjuvant trial, in this trial, the curves have started to separate even after stopping ribociclib. I was very interested to see what's happening to node-negative patients, because there was nearly equal benefit at 36 months between node-positive and node-negative patients. And this difference or this improvement in disease-free survival has continued even better, almost double in node-negative and in both node-positive patients. So we are waiting for this drug to get approved. I think FDA has already approved it, but as European Medical Association that is in the process of reviewing this, eventually it will come to UK and other parts of the world as well. And once it is approved, we will be able to provide stronger adjuvant treatment to even node-negative patients, which from these graphs, it appears that it is something which definitely will improve the overall outcome. Going back to ESMO venue, as I said, it was a great venue, multiple halls, big halls, and in between there was a food court, multiple restaurants, long queues. So you had to be there in time, otherwise you will not have your food before your session will start. And this is what I noted. There was an Indian Pakistani street food as well. And if there is Indian Pakistani food, the likelihood is it is a Pakistani restaurant. And it was very popular among the attendees. Quickly talking about another unmet need. This is a 50 years old perimenopausal patient. This is my patient. She presented with ER positive and HER2 positive breast cancer. There is a typo error, thankfully detected by Dr. Ali. It's not HER2 negative, it's HER2 positive patient. She had widespread bone metastasis, started on Cleopatra trial protocol, docetaxel, pertuzumab, trastuzumab. She had stable disease and stayed on this pertuzumab, trastuzumab maintenance for many months. I would say it was close to 2 years when she presented with headache and confusion. MRI scan showed large dural frontal metastasis. It was crossing the midline. She was discussed for SRS, but MDT felt that not eligible because of size. And neurosurgeon said they can't resect it because it was crossing the midline. The only option was whole brain radiation therapy, which is very toxic. Some of my patients, long-term survival, had whole brain radiation therapy in the early part of their disease. They have died because of whole brain radiation late toxicities rather than breast cancer. So this patient, obviously well-informed, did not want it. And we have this Destiny Breast 12 trial to tell us how we should treat this patient. So this Destiny breast trial, multi-arm trial, open-labeled, previously treated HER2 positive breast cancer patients with or without brain metastasis. In this trial, they actually looked at the outcome of patients in brain metastasis in particular. So what type of brain metastases were there? Stable brain metastases, which were treated previously, no evidence of progression in them, or untreated, but not requiring immediate local treatment, which means possibly slow growing, or previously treated and progressive. So what they call them, the untreated and previously treated, as active brain mets, and those who were stable obviously were sort of inactive or indolent brain mets. 157 stable and 106 active patients, 39 of them untreated, 67 of them previously treated and now growing. Median follow-up of duration, 15.4 months. So this cohort, active brain mets, is one which I'm focusing here for my patient. So what was the progression-free survival, which was the primary outcome? 12 months progression-free survival, 16.1 months. Median time, 17.3 months. So for nearly 1.5 years, these patients receiving TDXT have not progressed. And look at the curve, that how beautifully the tumor has shrunken and showed amazing responses. Overall response rate, 71.7%. So traditionally, what we say, that brain is a sanctuary site. Our chemotherapy can't go in. And brain is a site whereby bigger molecules like TDXT, which is a antibody drug conjugate, it can't go in. But that's not true. If you look at this graph, it's not only going in, it is also showing significant shrinkage. Very few patients have interstitial lung disease. So previously, the standard of care was that in patients who are HER2 positive brain metastases, we should use small molecules like tucatinib, which was tested in HER2 2-climb study. And now we have this Destiny 12 trial. Let's see how they both compare. Look at progression-free survival. 12 months, 24.9% versus 47% in untreated and 66% treated. CNS progression-free survival, 35% at 12 months versus 60%. So almost double. I think and response rate, 50 to 80%. So I think the choice is very clear. that if similar patient, which I showed, had come, should receive TDXT. So I used TDXT in that patient, which I have just shown even before this trial had come, based upon my experience with tucatinib in some previous patients and TDXT in some other patients who have partially treated brain mets. This patient didn't have any treatment for brain met, and you can see on the right side, this is the baseline scan in March, and then 2 cycles. The treatment was delayed because the heart functions were not good. We had to have an MRI scan of heart, which showed that the heart function was good, and we were able to start this patient on TDXT. Thankfully, patient stayed stable with steroids over time. 2 cycles of TDXT, and on the on the left side, you have the scan in April, near complete response. So this patient didn't have surgery, didn't have SRS, didn't have whole brain radiation therapy, just TDXT, and there was complete response. So ADCs are coming in breast cancer practice, but in the interest of time, I will leave this study so that we could have some discussion period. Finally, some thoughts on some interesting proffered papers which were presented. One of them was OptiTrain trial. So this is a trial of breast cancer patients who were receiving chemotherapy, and even after finishing chemotherapy, they were enrolled in 3 arms. In one arm, patients had concurrent resistant exercises plus high intensity interval training. It was compared with second arm, in which patients had concurrent aerobic exercises plus high intensity interval training. And then there was a usual standard of care as on the top. So these 3 arms, what was the rationale for this study? Exercise is suggested to reduce the recurrence risk in individual breast cancer patients. There is evidence regarding relevant physiologic mechanisms, but the evidence is not very clear. This trial actually looked at inflammatory markers, whose detail I'm not giving, but they try to predict responses on those inflammatory markers and try to predict recurrence events. So they followed these patients for recurrence, long study, randomized, controlled, 240 patients, the 3 arms, which I have already prescribed. There was strong association between event probabilities and biomarker, which means that these interventions have worked. Patients who were in both arms, they did better than patients in usual care in terms of recurrence. So there was something happening in the inflammatory markers. They were getting better, and the patients who were in exercise arm, they did better in terms of reduction in recurrence. Most impressive was the first arm, whereby patient had resistant exercises and high intensity interval training. They did the best. So this was a Swedish trial. I think we need Swedish diet and Swedish lifestyle to go into the first arm, because our population does struggle with doing strong exercises. There was another interesting trial, supervised structure, individual exercise. So in here, metastatic breast cancer patients, they were randomized into usual care, or they had 9 months of supervised exercise, more supervised in the beginning, less supervised at the end. And the outcome was to look at fatigue and quality of life of these patients. So exercise resulted positively in both outcomes. So physical fatigue was lower and quality of life was higher in exercise group than in control arm at 6 months. But then it started to decline because patients were less supervised. So exercise works, but supervision actually supplements the effects. There were 2 serious adverse effects, which was fracture, but both were not bone mets related. So that was reassuring. So that was my presentation. Just quickly telling you about the city. If you are in Barcelona, you have been and you have not been to Sagrada Familia, I would recommend you go. I have done multiple guided tours, but this was very, very impressive. And it's easy to get the booking. You can also enjoy flamenco dance. There are interesting concerts happening, and one of the best and easy way to tour Barcelona is through Barcelona tour bus. Thank you very much.
Thank you, Iqtedar, for a wonderful presentation. I hope people enjoyed it, and we certainly will start taking questions. But before we start taking questions, I just want to remind people that there are more upcoming events on different tumor sites. On 12th, there will be an updates on gynae, and on 19th, there will be an update on lung. Those who are interested in melanoma, they can connect on 26th of October, and urology on 2nd of November. I will repeat it again at the end of the session. Thanks, Iqtedar. There are quite a few important aspects which you have touched. They are relevant in real-world practice. We come across these challenges quite often when we are using different lines of treatment in different subgroup of breast cancer patients. You quite rightly said that adding immunotherapy certainly increases the pathological complete response rates, which can be translated into improving survivals. But without immunotherapy, where it is not available, or if patient cannot tolerate it, there are decent number of PCRs, and there is a decent survival. In real world practice, how challenging would it be for you if someone comes to you with a very weakly ER or PR positive? There is always a debate. We know that in trial they have said it quite clearly that it should be triple negative. But when we are dealing with weakly ER positive, like 3 on alert score 4, or if someone is falling between 1 to 10% ER positivity, PR negative, HER2 negative, what normally you do and how do you choose these patients for?
So in the scenarios which I presented, one of the scenario was real one. Patient was ER negative, PR4, HER2 negative. So what my practice is, we somehow use LRED in UK, or quick system in UK, which is not used in other parts of the world. I'm sure if tomorrow rest of the world says that we are using LRED, UK will say, okay, we are going to the ESCO cap type of scores. Anyways, so a patient who came who was ER0, PR4, generally in the trials, they say that any patient whose expression of estrogen or progesterone is 1% or more should be considered hormone positive, and those patients were not eligible in 522 trial. So in that patient, what we did was we went back to the pathologist and we said, could you give us the cap percentage of PR expression? And that was 40%, between 40 to 50%. So we did not give this patient immunotherapy. We treated that patient with 4 cycles of carboplatin, and this patient is now receiving her EC part of chemotherapy. So I generally do not do it. However, now we have data, if I'm not wrong, is it 752, in which patients who were grade 3 positive and there was low expression of ER, they were treated with immunotherapy plus chemotherapy in neoadjuvant setting, and the pathologic complete response rate had increased from 10% to 25%. So I would say that we have to take individual decision, go to MDT. In our MDT, there are different way of looking at it, and who is leading MDT, they make those decisions. But what I would say is that if patient is grade 3 and ER score is very, very low, and if your regulatory system allows you, these patients would benefit from neoadjuvant treatment. On the other hand, if your regulatory system says that you have to have ER negative, PR negative, HER2 negative disease, then probably those patients won't be eligible for that. I look at grade as well. So if they are low ER/PR and they are grade 2, I would not give them pembrolizumab. If they are grade 3, high grade, then probably, because some of these patients who are luminal B, like they have basal signature, basal breast cancer signature, and they would benefit from chemotherapy and potentially immunotherapy as well. You are mute for Vikas.
Thanks, Iqtedar. So the take-home message on this particular point is that we need to consider all clinico-pathological factors.
Correct.
And if somehow you are unable to give immunotherapy to these patients, still they behave like a triple negative. If they're weakly ER positive, PR negative, HER2 negative, still you can consider neoadjuvant chemotherapy, platinum-based, with a reasonable chance of achieving PCRs, and then eventually it will transform this into the improvement in other endpoints. So we start taking questions. I think, Avais, you were the first who raised the hand. There are a couple of more after you. So Avais, I'm unmuting you. Please introduce yourself, and then you are you're allowed to ask the question. Please, Avais, can you? Yeah.
Sorry, Avais, we can't hear you. You are muted.
Assalamu alaikum, both of you. Very nice to hear. And Iqtedar, I must congratulate you the way you initiated your presentation and you remembered your mentors. It was very humbling to see that. Although I personally went through conventional route of training, but I can share your experience because I had my humble beginnings under the auspices of Dr. Bhatt as well. So I'm a consultant medical oncologist in Essex, in Mid and South Essex Trust, with portfolio of breast and kidney cancer as well. So first point, I have a few questions for you. The first one is, I understand I wasn't at the ESMO this year, but there was the subgroup analysis presented in the 522 trial with Pembro. And the highlighter, I think there was that the high risk group, especially T3, T4 tumors, there wasn't any particular benefit of adding Pembro. Similarly, those patients who were older than 65, the trial failed to show any improvement in survival in this older than 65-year age group. So I'm sure you see in our MDT and our clinic as well that we somehow see that even chemotherapy toxicity in older patients, especially those bordering 70, is sometimes unacceptable. So I would like your comment on this. And the second issue, you very kindly presented the data from ovarian suppression addition in ER positive, HER2 positive patients. I would like your thoughts on ER positive, HER2 positive metastatic patients who are on maintenance Phesgo or Herceptin. I'm sure we have several patients going on for a few years. Do you think it actually makes a difference up titrating their hormonal treatment, although that was not allowed in the original Calopetra study? What are your thoughts on that? Thank you.
Thank you very much. Thank you for your kind comments. In terms of HER2 positive metastatic, my understanding is that their disease is mainly driven by HER2. And I would like to consolidate their anti-HER2 treatment as indicated. And the best way is to bring stronger antibody drug conjugates early on in the treatment. So now we can use trastuzumab deruxtecan T-DXd in the second-line setting, I feel is that their cancer is driven more by HER2 rather than endocrine treatment. And when they fail, all the available stronger anti-HER2 antibody drug conjugates, if I have to go, I would go with chemotherapy and anti-HER2 therapy. This is my thought, although we know that there is a trial in which we can't use generally or start our patients with endocrine treatment and HER2 positive treatment, but we know that there is a trial, I forgot its name, whereby addition of Herceptin to endocrine treatment alone improve the progression-free survival. So that's my take. I would use ovarian suppression.
Yeah, my question was, sorry, was in the maintenance phase once they come off the chemo,
right,
and they go on the maintenance before progression. You know, whether you consolidate your hormonal therapy.
I'm not aware if there is data or if it is, I'm not aware of that, but I would not, because these treatments have their own toxicities as well. If patients are younger, which means they are premenopausal, and that's why we are adding ovarian suppression in those patients. They are quite toxic. They change life of patients. I would concentrate more on HER2 therapy, anti-HER2 therapy, rather than and stronger and make it more as good as possible, rather than working on anti-estrogen treatment. But obviously, different people have different opinion on that.
Just a very quick comment here, Awais. If I understood well, that you're talking about the maintenance phase of metastatic ER positive, HER2 positive breast cancer patients?
Yes, yeah.
Right. In Cleopatra trial, the patients who were ER positive, they were not given endocrine part of treatment at the time of maintenance, pertuzumab and trastuzumab.
True.
Hence, their survivals, their outcomes were slightly worse than ER/PR negative patients. But in real world practice, we try to add endocrine therapy when they are on anti-HER2, dual anti-HER2 blockade. And that obviously helps in addressing the estrogen sensitive aspect of breast cancer. I totally agree with Iqtedar that the main driving force in these cancers are HER2 positivity. But in this heterogeneous group of breast cancer, where estrogen sensitivity is also one of the aspects in breast cancer, in trial, it was not given, but in real world practice, I think majority of our colleagues, they do add endocrine treatment when they are on dual anti-HER2 blockade. Obviously, when we start then subsequent lines with the antibody conjugates, the traditional practice is not to give endocrine therapy when they are any sort of chemotherapy, either in ADC form or non-ADC form.
But regarding ovarian suppression, what are your thoughts, Waqas?
I think ovarian suppression is another important. If there's a premenopausal, we tend not to give ovarian suppression. We rather give tamoxifen with trastuzumab and pertuzumab. Ovarian suppression in HER2 positive disease is something which would have their own consequences, because ovarian suppression is quite toxic when we give it. So we usually restrict it to the younger patients and ER/PR positive, HER2 negative patients.
Yeah, my question had only arisen because of the data set that Iqtedar has kindly presented, that seems to show that it makes a difference in the adjuvant setting. So that's why I asked the question.
No, that's a very pertinent question. And I think that is one of an important aspect of future trials or exploration, that can ovarian suppression be safely added to these cohort of patients who are estrogen sensitive and HER2 positive, and would there be any consequences to the HER2 anti-HER2 treatment or not? Thank you.
So over to you, Iqtedar, for the second question on the subgroup analysis. That was very interesting. Yeah.
So sorry, which one you mentioned?
So there was subgroup analysis presented for the 522 pembrolizumab neoadjuvant study in TNBC, which showed they presented in the subgroup analysis that T3, T4 tumors.
Yeah.
It doesn't seem to make difference. Similarly, patients older than 65, there wasn't a significant survival benefit from addition of pembro.
I mean, I totally agree with that. There are different subgroups, like patients who have, if you look at the residual cancer burden, again, the benefit was more if residual cancer burden was 2. In residual cancer burden 3, 0, and 1, there was minimal benefit. But we have to take subgroup analysis with caution, because most of our trials are powered to give us definitive outcome on primary endpoint and possibly secondary endpoints. They are definitely exploratory, and in individual patients, they can be helpful in making our decisions.
Thank you very much. We would now move to our next participant. Kalsoom, can you please unmute yourself and ask the question? Thanks, Abbas. Sorry, Kalsoom, we can't hear you. You need to unmute yourself first. That's better. Thank you.
Vikas, we can't hear you now.
Sorry, Kalsoom, we can't hear you. Can you unmute yourself? No, I think you can. I'm sorry, but we can't hear you. You can post your question in the chat if you like, and I'll take the priority next one. Zafar Ali.
Thank you so much, Dr. Iqtedar, for your nice presentation. And I always be happy with your meeting and Dr. Bhatt as well. My question, I come to the point because we have made a short of time. Regarding the NATALEE trial, particularly for ribociclib. So first, and one comment, because they include the N0 diseases, but not all. They have defined some criteria about this one, especially like N0 with grade 2.
Yeah.
And
high risk.
KI and grade 3.
Yeah.
Very interesting. They also mention oncotype DX, supposed to be N0, but should be more than 26. So they include in this one. Yeah. So is there any, because usually we go for chemotherapy or adjuvant chemotherapy.
Yeah.
So they want to go for adjuvant like CDK4 inhibitor. Secondly, if the patients usually standard of care nowadays is 2 years abemaciclib, now the ribociclib for 3 years. So in future, did you think you extrapolate the result, and can we continue those patients are on abemaciclib for 1 more year, or we will stop it at the 2 years?
So I think these are very difficult questions to answer. Generally, we follow our clinical trial setting, and even 3 years of abemaciclib, once we stop, now we have long-term data. I think it's 6 years data, which we have available now, and the graph is separating just by just after 2 years of abemaciclib, the graph is still separating after 5 or 6 years of available data. So I would stick to the trial design, which is 2 years of abemaciclib and 3 years of ribociclib. You are right in terms of oncotype DX, 25 plus patients go for chemotherapy. And it would be interesting to look at the trial, which I don't have the information how many of those patients receive chemotherapy before starting ribociclib.
One quick question regarding this one. If the patient having started already adjuvant therapy and treatment, once they are progress, or have a metastatic disease. So what will be the option for us, especially the early recurrence?
So I think this is again something which is an unanswered question. We have to look at future trials to make a decision. The based upon our practice, I would say that if patient has progressed after a year, we should be able to re-challenge them with CDK4/6, provided we have regulatory approval. So far, we do not have regulatory approval in UK. If somebody progresses on CDK4/6, generally we cannot re-challenge them. But this would be something to follow in future.
Okay, thanks so much.
Yeah, these are important points, Ali.
Very
Thanks.
important. Very important.
Just to clarify that when somebody is progressing on adjuvant CDK4/6 inhibitors, you cannot re-challenge with any further subsequent CDK4/6 inhibitors. Your options would be either to go on other systemic treatments. You can do PIK3CA testing. ESR1 is really done to check the resistance, but the trial in which the elastrant has been used, the patients who are progressing on adjuvant CDK4/6, they are not the best ones to offer elastrant. So there are various options, but not the CDK4/6 re-challenge anymore. Thank you. So I probably would move on to the next one. And I can see a few more hands up.
Thank you, Dr. Iqtedar. Very good presentation. It's Iftkhar here. So I'm a consultant clinical oncologist in Cambridge. So there are a few points with regard to keynote 522. I think we are, first of all, the most important thing is we are talking about young ladies, more of them, who have got curative disease, and we're considering the very toxic treatment. So if we look at the trial data, so it talks about survival. It does not talk about cure. So we need to be clear about this, first of all. So it talks about any patient, regardless whether they recurred or whether they had metastasis. It is talking about survival. Okay, so there is a survival difference of about 5%. And it does not take into account of what subsequent treatments patients receive after they got metastatic disease. Okay, so that's a very important point. I mean, we don't know whether how many of them had received Trodelvy. We don't know how many of them received single agent, dual agent. So this is the other thing is, if we go into the subgroup analysis, I think on the trial data, it says roughly that there is no difference in toxicity, but there were 0.3%, which means 3 out of 1,000 young women will die in immunotherapy arm. So we need to be mindful of that. The endocrine toxicity, cardiac toxicity, all are more. And in real practice, what we see, I don't think even more than half of the patients complete all 8 cycles of neoadjuvant pembro along with 8 cycles of treatment. So less than half. The other thing is, once the patient has received the complete response in neoadjuvant setting, the subgroup analysis show there is no difference of survival, whether you go for placebo or whether you go for immunotherapy. T1, T2 showed significant survival, but not T3, T4, as Avas mentioned, and not for above 65. So we are talking about neoadjuvant and adjuvant treatment in those patients where about 60 to 80% of the benefit is coming from like surgery. So we really need to select patients very careful, I think, in this. And I'm not sure, I mean, yeah, so hopefully we will have some data about real world practice very soon, where we will know where is the actual benefit. So we need to be mindful in selecting patients. I think if the patient is very fit and well, then and we can consider. But in this trial, I think they have used very, very fit and well patients. In real world, we don't see those fit patients. That's my comment on this one, keynote 522.
No, I cannot agree to it more. I mean, thank you very much for your comments. Well taken. So my take is that there are some horrific side effects of immunotherapy. You mentioned myocarditis. There were few deaths, more in the immunotherapy arm, more because of cancer or related to cancer or related to complications, few maybe because of immunotherapy toxicity. But we also have to remember that high-grade toxicities, immune-related toxicities are uncommon. I would say figure of like 5 to 10%, maybe less, which means 90% of women, 90% plus will not have high-grade immune toxicity. The incidence of myocarditis would be less than 0.5%, very, very uncommon. Diabetes, 1 in 400, adrenal insufficiency, 1 in 800. Thyroiditis or hypothyroidism, you use Ipinivo. We don't use it here. It's like can go up to 40%. Here it's 10 to 15%. However, as you alluded, some of these toxicities are very important even for very fit patients. They don't want to take insulin injection even if there is a remote chance that they will end up with, while knowing that there is a good chance that their cancer will be cured. Knowing how the immunotherapy data is panning out, it will be quite challenging not to offer immunotherapy to right patient. But I think after offering immunotherapy, a role of clinician will come here, how they discuss risks and benefits. And obviously there will be patient, less breast cancer, more other cancer sites, patients would be declining immunotherapy treatment, because in breast cancer, I don't know what is your experience. My 10 years plus experience in this cancer is patient, if they have even 1 to 2% chance, they will come to you and they will ask for that treatment. Younger you are, more treatment you want, and that's true for even older patients. Some of the very senior patients come and they ask for lots of treatment. This is job of clinician, as you very rightly said, to look at the data, to see whether your patient is the one who is going to get more benefit, or the balance is towards more toxicity, more quality of life problems. Thank you for your comment. Very well taken.
Yeah, I think thank you. So there's a lot of media publicity with regards to immunotherapy, and every woman, even regardless of what type of cancer, they ask for immunotherapy. So I think the real world toxicity is significantly more as we get in the soil. So, and I think I'm not sure. I've got limited experience, but in my experience, elderly women, they slightly like above 60, they tolerate it better than as compared to younger life. I think mainly because in a younger woman, their immune system is very functional. So that's why they get. And I mean, I had come across like 2 very unfortunate cases where patient developed all sorts of toxicities, including GB syndrome, myocarditis, all that. And so but
thanks,
thanks,
Iqtedar. Point taken. The real world practice obviously gives us different challenges. These are not the ideal patients as presented and chosen in the trial. Thank you. We move to Afan. Afan, can you unmute, please, and ask the question? Thanks.
So this is Hassan here. I think I'm just using some different device. So
all right. So please,
thank you.
Yeah, thanks, Hassan. You're welcome. Please ask the question.
Thank you very much for presenting some nostalgic images of Shaukat Khanam, and it was lovely to work with all those people. I think just a couple of moments. I think so. Comment number 1 is that Bristol is leading on collecting some real world data. So I will strongly encourage my colleagues to think of joining with them, because I think the toxicity is definitely underreported. I work at the Christie, and we are also collaborating with Bristol and trying to provide data from our end center as well. Secondly, I think the consent, I think probably most of the colleagues are still using CRUK consent form, which is the right thing to do, because you have to be very cautious. You use the right consent form which have all the informations, because as treatments are curative, people have long to live, and immune toxicity can happen anywhere in your phase of life. So it's important that the consent is pretty precise, clear, and clear document. Thank you.
Thank you. I totally agree. And this is what my understanding of or my experience is, that discussions are more difficult if you are using immunotherapy in adjuvant or neoadjuvant setting, any cancer, especially those cancers who are more curable, like melanoma. The discussion of immunotherapy, melanoma some of them can be cured even in metastatic setting. So the discussions are longer, they are more difficult. In breast cancer, once again, majority of patients, huge number of patients will be cured without immunotherapy. So we will be spending more time in discussion of perioperative, curative immunotherapy settings as compared to in metastatic. We are dealing with life-limiting conditions.
And the second thing, Darba, is surely if you have residual disease after immunotherapy, then and there's a BRCA mutation, then I think the survival advantage, secondly, with olaparib. So I think most centers are moved toward that practice, and that will also, we don't know in the real world data how much that will compound the survival advantages when we look at it.
The other important point is addition of capecitabine in residual cancer, and obviously we don't have any data, but there was a very good poster from Korea, which was not prospective. Obviously, it was their retrospective data, but very well covered. And in those patients with RCB3, the addition of RCB4, addition of capecitabine has resulted in significant improvement in a reduction in IDFS, but that was obviously retrospective data, not randomly collected.
Thank you, Iqtedar. Hassan, thanks. The next person is Shahid Iqbal. Can you please unmute yourself and ask the question?
Thank you very much. I am Shahid Iqbal. I am currently working as consultant medical oncologist in the Mater Hospital in Dublin, Ireland. And thank you very much, Iqtedar, for a very nice overview of ESMO breast updates. And it's lovely to see all you working and progressing in the UK. And thanks, Syed Ali Raza, for sending me the link of this meeting. And it's really helpful to get the updates. My question is, my couple of questions, they are centered around triple negative breast cancer management in the early settings. With Keynote 522, when you treat a patient with high-grade tumor who has some ER positivity, weak ER positivity, like less than 10%, if you treat these patients with chemoimmunotherapy as per Keynote 522, will you give in the adjuvant settings, would you recommend to give endocrine treatment in those patients because of very small ER positivity? Traditionally, we were not using, like when I was a trainee here and now I'm working as a consultant, we were not giving. But now the most recent data, it is showing some improvement in the overall survival as compared to those patients who are not offered adjuvant endocrine treatment in these technically triple-negative breast cancer patients. And my second question is about if the patients, they have residual disease, would you have any experience of combining pembrolizumab with capecitabine if they are BRCA wild type, or pembro with PARP inhibitors if they have BRCA mutation? I know it is not still the standard of the care, but there were some studies presented like it could be safe, like there are no safety signals issues like in some of the clinical trials. But what is your real life practice? Because we are seeing these patients more and more in our real life, and we don't have any clear-cut guidelines.
Indeed. I mean, I'll come to the second question, which is for me, it's easy one, because thankfully, most of my patients who have received chemoimmunotherapy, they have a complete pathologic response. In one of my patients had quite substantial residual disease, and after discussion, we treated that patient with 6 months of capecitabine along with pembrolizumab. And thankfully, she has finished both of them completely. She's on follow-up, I think 6 to 8 months down her treatment and still in complete remission. There were a couple of my patients, actually one had complication, the other one had progressed on immunotherapy and chemotherapy. And that was very odd because in my practice, I have not seen patients progressing. Yes, in the trials, if you look at older neoadjuvant chemotherapy trial, there will be like 6% of patients who would be either stable and some of them would progress, but one of my patients definitely progressed, and that had gone into post-op. We managed to operate the tumor, but she developed very quickly metastatic disease, and currently she is on capecitabine in metastatic setting. In terms of addition of endocrine treatment, that is a very tough question. But if we want, these are the patients in whom it's difficult to determine their actual behavior without doing their proper molecular signature. Molecular signature will tell you whether they are behaving like basal or they are behaving like hormone receptor sensitive patients. So if given opportunity, I would treat this patient, give this patient a trial of adjuvant endocrine treatment as well. You are right that traditionally we don't, but recently in ESCO we had this population-based data in which patients who were ER low, they had achieved some benefit from endocrine. Actually, there was significant loss of disease-free survival in those patients if you omit endocrine treatment with them. So I would try that. If they tolerate, I would complete 5 years. But the question is whether these patients should get immunotherapy. That's again a very tricky one.
But do you give immunotherapy in low ER positive? Like you mentioned OLED score, like here in Ireland, some hospital centers, they are using OLED, some are using percentage. Yes. So percentage wise, it's very, I think, easy to make decision. Like I had a patient recently who had just 2% ER positive. So I'm treating that patient with Keynote 522 regimen because it is just 2%. Like I don't feel justified like not to give immunotherapy.
Yeah. So my practice here is that if they have low LRID, like 2, 3, what I ask my pathologist to give me percentage. So your pathologist can look at the sample and give you cap percentage. And I make my decision based on that cap percentage. So generally, if it is 10% or more, it's definitely ER positive. We should not treat those patients as ER negative.
Great. Thank you very much.
And the little thing I would like to highlight here, because if you look at this trial data carefully and as the way Iqtedar presented, if you think that there will be a benefit with adjuvant endocrine treatment to an extent, again, there is a very decent pathological complete response rates without adding immunotherapy with platinum-based neoadjuvant chemotherapy, and then nobody will stop you adding endocrine treatment in adjuvant setting. And obviously, if you don't give immunotherapy in neoadjuvant, the patient will be deprived of having immunotherapy in adjuvant setting. At that point, if there is less than complete response, you can think about adding capecitabine if it's BRCA wild type, otherwise olaparib.
The problem is these are evidence-free zones.
Yeah.
So data-free zones. So it's very difficult to give a very conclusive answer. It has to be individual practice, but yes, discussion with colleagues in the MDT, that is a very good way of getting a relatively better answer.
Right. Yeah, so we move on to the next person raising hands. I think Tahir Bashir. Thanks.
Thank you. Assalamu alaikum. Good afternoon and good evening, everyone. This is Dr. Tahir Bashir. I am Assistant Professor of Medical Oncology at Faisalabad Medical University. Excellent talk, Dr. Iqtedar. My question is not about the recent ESMO, just to exploit the opportunity to talk to a breast oncologist We rarely see brain metastasis in ER positive population, but whenever you come across a case like ER positive and brain metastasis, which CDK4/6 inhibitor you prefer or your thoughts about it? And the next part of my question is, have you have any experience of using antibody drug conjugates in earlier lines while managing HR positive, HER2 negative breast cancer? And last part is regarding the mutation testing. I mean, when your patient has a disease progression on CDK4/6 inhibitors, you go for NGS or you check mutations individually. What are your thoughts about the mutation testing? Because this is a costly business.
That is right. So in terms of patients on CDK4/6 developing brain metastasis, uncommon, I think less than 15%, but it can happen, and it has happened to my patients as well. And these are, many of them are, in my experience, they are luminal B. They are ER positive, PR negative, HER2 negative. And these are very, very difficult patients to treat. Their behavior is still not completely known. I treat them with local therapy. And if the systemic disease is under control, I tend to carry on with treatment. Generally, systemic disease progresses as well, and you have to change the treatment. I have a couple of patients in whom there were small brain mets. We managed to, one of patients actually had surgery, other patient had focal therapy with SRS, and systemic disease was under control. So we carried on, but those patients progressed within next few months. The second question regarding use of antibody drug conjugate in hormone receptor positive, HER2 negative, I do not have experience. We know we have data. We have data for many antibody drug conjugates in this setting. But in UK, they are not approved. In private practice, I haven't actually come across any of those patients. And in Hull, we did not participate in any clinical trial in which these patients were used in that way. The third question is regarding post-progression. So what we do in terms of getting molecular analysis. So generally, we PIK3CA, we check it on tissue. However, we are sending more and more Garden 360, which is the circulating DNA liquid biopsy test, but it's not approved by the regulatory authorities, so patients have to pay for it. But we are not able to get a whole genome sequencing on tissue in our patients. It is available in NHS in different centers. Maybe Hassan will be doing it in Christie's, but we don't have pathologists. We started to do it. I have done it in one of my breast cancer patients, but then the pathologist who was trained to look at those samples had left our organization, so we could not do that. So our practice is that going for whole genomic sequencing, generally we go for liquid biopsy. And if we are going for that, patient had to pay, unfortunately. Indirectly, I'm saying we are not doing it a lot.
Thank you.
Just a quick comment I would like to add, Tahir. When we're talking about drug antibody conjugate, the Destiny 4 data, I think you're talking about HER2 low population. Is that right?
Yes.
So in the Destiny 4, there is a data to use it, but that has not been approved in NHS so far. But out of NHS, there is a strong, reasonable evidence to try it. The second thing, we do a smart NGS or selected molecular testing. But when you're opting for molecular testing, you always need to think about that what targets are you choosing, and is there any drug available to offer the patient afterwards? Especially if you're doing PIK3CA, you need to be careful that fulvestrant has not been used previously. If the fulvestrant has already been given to the patient with CDK4/6 inhibitor in first line, there is no point of checking PIK3CA. Yes, ESR1 can be done, and other molecular targets. If there is any drug available, then yes. I would like to ask Hassan to comment if you're doing anything different in Christie, Hassan.
I think the NHS practice is similar. There's a target study going on, which is looking at offering a whole genome sequencing to patients, but we're all in the same boat in the NHS practice. The only I would like to add a couple of comments about, because I think the capecitabine was discussed earlier on.
Yeah.
I think the residual disease concept, I think there won't be any appetite with the trial with the pembrolizumab group to see what's the advantage of dropping adjuvant pembrolizumab in those who have residual disease. So in BRCA mutant patients, I think that the practice in the bigger center is that if the residual disease, you drop the pembrolizumab, consider olaparib. But in the capecitabine is again, I think it has to be very carefully discussed here because it's an evidence-free world. We don't want to we're combining two drugs where there's no regulatory approvals. And it has to be a wind of caution, because if things go wrong, then medico-legally we can be in a difficult position. Thank you.
Yeah, agreed.
Yeah, sorry, just to add, because on this one, I think there's a trial called PBCP led by Cambridge, so where they do test all the whole genome sequence. I think it's now rolled out nationwide for the last couple of years.
Sure.
And so, with just a quick question, can we ever combine capecitabine with pembro? Has anyone done this in patients with residual disease?
I think I can only comment from because I work at the Christie, so I think we don't do.
I mean, as I mentioned, that there was a Korean, there was a very good poster. If you have looked at posters, there were some very interesting posters in ESMO, and there was a poster retrospective analysis. A huge population, patients were like more than 500, and you can actually look at ESMO posters to go. There they combined the capecitabine with pembro in patients who had the RCP4 type of disease. Sorry, RCP3, actually, I am saying 4. It's RCP0, which is complete response, 1, which is near complete response, 2 is moderate, and 3 is when there is no response. So in those patients... So in those patients, there was...
Sorry, we need to go one by one. Can you please mute your mics and raise your hands? I will be more than happy to give you an opportunity. There is somebody whose mic is not muted. Okay. I think in the chat, there was a question from Fatma Khalid about guidelines, how to manage the adrenal insufficiency. That has been answered by another colleague here, which is fine. Is there any question? Please feel free to raise your hands, and we would ask you to unmute yourself. Right. So thank you, Iqtedar, and thank you everyone for connecting on Saturday. I would like to...
I think there is a question on Vikas.
I would like to share once again that the upcoming meetings on different tumor site updates, please note it down. Gynecology updates will be on 12th of October, and then lung on 19th, melanoma on 26th, and urology on 2nd November from the same forum. There'll be different presenters and different moderators. And I wish you all the best. Have a lovely weekend. If there is anything you want to ask on breast cancer, you can drop us a message in our WhatsApp group or individually if you want to know more about it. Thank you. Thank you
very much. Thank you, Vikas. Thank you, everybody.
Thank you so much, Doctor.
Thank you.
Thank you so much.
Thank you.
Earlier.
वालेकुम ताहिर।
वालेकुम अस्सलाम।
कैसे हैं आप ताहिर? सही
भाई आप सुनाएं, आप कैसे हैं?
अल्लाह का शुक्र है यार। मैं बड़ा
देखें आज आपको पकड़ लिया हमने, मीटिंग के अंदर में से ढूंढ लिया आज
आई एम
आपको।
वेरी हैप्पी। मतलब मुझे बड़ा अच्छा लगा कि मैंने ताहिर बशीर नाम देखा, मैंने कहा यार सड़ा ही तार है पानी है।
और सब खैरियत है?
जी अल्लाह का शुक्र है। अभी
आजकल
आपका
यूके में सेटल?
जी जी वहीं पर ही आजकल मैं।
माशाल्लाह।
तो आपका ये नंबर या तो चलो ठीक है, मेरे पास नंबर अभी फिलहाल नहीं, मैं ले लूंगा। तो विल ट्राई टू कीप इन टच विद यू। ठीक है।
हाँ नहीं, मैं आपको नंबर भेजता हूँ ना, आप मुझे अपना नंबर लिखवाइए।
मेरा 07
मेरे पास अभी ये जो
044।
कॉल आ रही है आपकी व्हाट्सएप से आ रही है?
मैं अभी तो नहीं कर रहा था भाई आपको कोई कॉल।
अभी आप मीटिंग से बात कर रहे हैं? कहाँ से?
जी जी मैं मीटिंग से ही कर रहा।
आपने
बाकी काफी
मीटिंग के अंदर से
ऑफलोड हो
बात?
गए।
अच्छा 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 अच्छा, मजा आ गया भाई। ये तो फिर फ्री में, देखें फ्री में हमें वो जो मिल गया ना एयर टाइम,
जी जी यही है।
एयर टाइम का ये फायदा भी हो गया।
तो
मैं जो है, मुझे अपना नंबर लिखवा दीजिए, मैं आपको फिर कांटेक्ट करूंगा।
0044
0044
73
73
88
88
63
63
781।
781। थैंक यू जी जफर भाई, बहुत खुशी हुई आपकी आवाज सुन के।
जी इंशाल्लाह।
और बाकी फिर इंशाल्लाह आई विल कीप इन टच इंशाल्लाह।
ओके हाफिज, दुआ में रखिएगा इंशाल्लाह भाई। अस्सलाम वालेकुम। अल्लाह हाफिज।
वालेकुम अस्सलाम।